Hello and welcome back to SPT with J and Z. I'm Zach Carson.
I'm Josh Griffith.
And this is week 4. Oh, this is our 4th video, week 5 of the Grand Valley State University Doctorate of Physical Therapy program. We're very excited going forward because this week is big week. Big week. I'll just put it at that. We've got, why don't you break it down? Why don't you tell them what we have this week?
All right, so first on Monday, we have our Intro to Evidence-Based Practice quiz, probably on the least nervousness scale, I guess, for that one. But then we have our practicals in kinesiology, our written exam in kinesiology, and our first clinical science exam. So a lot of content in 4 classes. So lots of studying, not much sleep. Got a lot of intramural games this week too. Playoffs coming up tonight, 2 games hopefully, if we keep playing for softball.
I'll be there in spirit.
Yeah, well, I'll be there really late tonight and then coming to class early tomorrow. But
I'll be sleeping.
yeah.
All right.
Still fun times though. So quite a bit coming up, but we'll break down last week for you.
Yeah, and also if you notice, I got the Michigan hat on and the Michigan helmet out. That's because it's Michigan State week this week. Hate state, beat state, whatever we got to do. I'm just going to be flaunting the M gear. A lot of our classmates are state fans. A handful of them graduated from Michigan State. So hopefully I'm wearing a lot of maize and blue this week and really putting it at them. I believe the opening line in Vegas was 17, which is too high, but it should be a good game. I'll actually be there.
Really?
Yeah, Liz and I are going. We have really good seats.
That's pretty cool.
So we're going to go down to Ann Arbor and hang out post heavy exam week. So hopefully it's a good celebration. All right, so with that being said, let's go ahead and jump right into the content. Josh is going to take us through anatomy to start us out.
All right, so this week in anatomy, we had our first exam. So there was a lot of stress last week in coming up to that one for us. We came out, I think overall, the professor said we had like an 85% average, which is pretty dang good.
That's really good, yeah.
Pretty good for the first one, not really knowing what to expect. Maybe a little lenient, gave us some extra points, but still pretty proud of our class for doing that. Day 2, so we just jumped right back in on our next unit. Wednesday, we start out with the skull, so we're going into the face and neck, or the head and neck regions now. But we looked at the skull, looked at all of the kind of just projections off of bones in the face that you don't really think about. There's so many bones in the face.
A lot.
So many. But it was good to go through the list. There's several structures throughout, and it's the most I think we've had in any one lab, but we're getting more confident as we go. So I think having a good base through the first exam, now we know what we need to do to study. So we're going to be all right, I think, in that class now. Just need to get the first one under our belts.
Benchmark.
Yep, exactly. So rolling into kines, which is on our minds all the time right now.
Yeah, like Josh said, we have our lab practicals and our first written exam in kines this week. So it's pretty heavy. We just finished actually practicing a little bit of palpation on each other just for preparation in that class. We go back to the lecture portion. We ended last week talking a little bit about the biomechanical properties of the discs and lumbar spine kinematics. So we jump forward off of that into axial compression and distraction. So we talked a little bit about axial compression. There's 2 ways that the disc will compress, and either it can be weight bearing, so if you load weight on your back or you're carrying weight through your hands or over your head, it can load those discs, and also just by tensioning those muscles, contracting those muscles will actually add compression to those discs also. We also talked about when that happens, that with that compression it can transmit equal distribution through that disc. And then if you have any kind of additional forces, i.e. like a rotational force or something, that's when you get that radial bulging of the disc and kind of the antero or the posterolateral herniations or bulging of the disc that can lead to so many problems in people. And that can be acute or that can be chronic. It can be slowly developed over time chronically, or just like an acute motion that shoots that disc out depending on the hydration levels and everything else. So speaking of the hydration levels, we talked about how the disc loses its hydration throughout the day. 8% through the nucleus pulposus and 11% of water through the annular fibrosis. And then then we talked about that being depending on the load that you have throughout the day. So in a standing posture, the weight has 100 kPa on it, and then we talked about different charts when you're sitting, when you're standing with a load, different postures that you're in that can either increase or, like lying down and taking the load off the spine, decrease that kPa. Another thing we learned about was disc creep. So throughout the day, that disc slowly shrinks. That's why they say at the end of the day that you're, shorter as a person because your discs are dehydrated, and then when you wake up in the morning, you might be a little bit taller. So just to break that down, in a 16-hour day, a disc may lose 10% of its height and 16% of its volume, which equals in result of 1 to 2% shorter by the end of the day through all those discs, which can be restored just by resting or reclining. Then we jumped into, that was kind of the end of the lumbar spine kinematics that we talked about, and we jumped a little bit into cervical, not far. We just kind of got into the upper cervical versus lower cervical. So you have the OA joint and the AA joint, which consist of your upper cervical, and then C3 through C7 is your lower cervical. Talked about the coupling patterns in that. The OA and the AA have an opposite side coupling pattern. So if you side bend right and rotate left, that's going to be coupled up in that upper cervical region. And if you side bend right, rotate right, you're going to have a coupling pattern in that lower cervical region. That pretty much concluded what we learned this past week. In the lecture portion, we have to finish up with cervical prior to our exam, but that was pretty much all the material, and we're ready to rock and roll on that. And then we rolled into the lab, which Josh is going to touch on briefly.
Yeah, so we were finishing up lumbar spine, I believe, going into more of the cervical, and I think the cervical region has been the toughest for all of us. The muscles are pretty small. Those bony structures are really deep to those muscles, and just like throughout the rest of the program, some guys, some girls are easier to palpate than others. And another added I would say obstacle is trying to learn how to get to deep muscles like the suboccipital muscles when the patient is laying supine. So I think that trying to orient yourself from sitting is easier. You can kind of visualize where the muscles are running, but when the patient's laying down on their back and you're trying to feel up underneath their neck, it's a lot harder. So we just practiced that. That was one of the things that we wanted to make sure that we're feeling more confident on, is getting ourselves oriented in a position that we may be kind of blind in. So overall, I would say most of our time was spent on the cervical spine this week. We also did our quizzes. We did a quiz to get our feet wet going in. I know for myself, I wanted to make sure I had a little practice going in to the practical this week, because it's definitely a high stress situation if you haven't done it before, and it's a skill that we're learning still and going to continue to learn. It's not a book smart skill. It's an actual practicing technique that is going to be useful every day in the clinic. So yeah. I don't know what your experience was like. Mine was a learning experience for sure. Knowing the origins and insertions is still on my list of things to do. And that was really where I found that I was weakest in the quiz. I was able to find the structure, able to test it pretty well, but knowing each place that originates and inserts is always going to be more repetition, more practice.
Yeah, and then getting that confirmation with some kind of movement.
Exactly.
So palpating the structure might be pretty easy. Knowing those origins and insertions in general tends to be pretty easy. Being able to find point A and point B, and I know the muscle bellies in between, but being able to say, oh, it's the spinous process of C7 and T1.
Right. The minute details.
The minute details like that. And then getting that innervation, obviously. We also hit some muscles on the face.
Yes.
Did the old hook finger in the mouth for that medial pterygoid.
I actually never did it. So my partner was still good, but it's definitely invasive. Another one of those invasive techniques that we will have to do at some point probably with the patient. So it's good that we're getting in and practicing those on more of a comfortable friend, so you can get used to dealing in those uncomfortable positions. So. All right, so you want to take us on to our foundations?
Absolutely, I can do that.
Appreciate
All right, so foundations and PT exam this week. We started covering reflex and sensory testing. So a lot of us are pretty familiar with what reflex testing is. You've been to the doctor, you sit on the edge of the table, they hit you on the patellar tendon and your foot flips out. Great, reflex testing. What does that give us? That gives us information on the integrity of the nervous system, also the PNS, the afferent and efferent nerves, and then also the ability of the CNS to inhibit a reflex. So you have a couple of different things there. Some people have really high reflexes and some people have really low reflexes and some people really don't have any reflexes at all. That can mean a couple of different things. That can mean that they have some kind of impairment via the nervous system. That could also mean they just don't have a very high reflex. I mean, as long as you compare bilaterally, if they don't have it on both sides and you mark it as a 1 or a 0, that's a normal response for them because everybody's different. So with that being high and low, you have hyporeflexia being low. It's generalized or non-generalized, and it can mean a couple of different things. And then hyperreflexia being, it's very high, so you would grade that as, we talked about our grading scale, 0 through 4+, and they said don't ask why they have a plus in there because it doesn't make any sense, which is 100% true.
Yeah, I don't understand.
It doesn't, I mean, you could put like a 0.5 or something, I guess, and it would make more sense, but plus. So a couple of different things to deal with there, and then we also talked about sensory testing, and this is a little bit newer to us because we may have had some basic sensory testing in our physiology labs. I remember doing that in undergrad where we did like the 2-point discrimination. Yes. I do remember doing that. However, this is light touch, sharp dull discrimination, a temperature discrimination, a 2-point discrimination, a vibration testing, stereognosis, and monofilament. So we working through the dermatomes of the upper and lower limbs, so learning what nerve roots coordinate what area of the skin, and that's a lot of things going on there. So, you know, C6, 7, C8, and the way that it travels up your hand, you have to be able to know that from the top all the way down. So when you're doing that light touch, you have to be able to take that cotton ball and touch them on different areas of their arms or their legs and know that you're working within that dermatome, so that way you can relate it back to what you might think it is injury-wise. So we also learned the peripheral nerve endings. So we talked about dermatomes typically end up being a root issue. So if their C6 dermatome might be impaired, they might have damage, you know, they have some kind of neck pain, they might have damage to the roots and maybe in the brachial plexus somewhere. Whereas something fell on their lower leg at work and they have like a pain through their lower leg in a certain area and you can isolate that, then it's most likely a peripheral nerve lesion and not so much a dermatome because you can't trace it back up to a nerve root. So we're kind of working on, first of all, memorizing where those dermatomes and peripheral nerve endings are, and secondly, how to go through that testing process to delineate between the degree of what they might have damage-wise, and then if we could possibly relate that back to like their CNS. So that's what we're kind of learning in there. The reflexes was easy. We did biceps reflex, brachioradialis reflex. We did triceps reflex, patellar reflex, and then Achilles tendon reflex. I actually found a couple of people were pretty lacking, maybe a 1 or a 0. One girl I did, she was a 0 on her right leg and a 1 on her left leg and her patellar, which is like supposed to be the best of the best. So
I would even say mine were diminished, but what we found was if they could really distract me, like somebody have a conversation kind of in the distance, then they could elicit a reaction much easier. Mm-hmm. So like my patellar was not, it was like a 0. It was like a 0, and I was doing all the other tricks in the book, like clenching a fist, looking away, just all of those things weren't working, but then we found another one that could elicit the response like as normal. So that's one thing that you don't think about, I think, for me anyway. I wouldn't have, I was like, maybe I just don't have that good of reflexes, but it was just the fact of I've kind of developed the habit of really focusing on not having a reflex to something maybe. So yeah. A distraction to the patient would help in that case.
Yeah, so this week I don't even remember what we're doing this upcoming week, but
No,
Probably
pretty
just-
focused on
yeah, it's funny
I
how
don't
the
know.
thing of the scope of other classes kind of fall out, but not exactly the best practice. Oh, you know what? We're doing measurements this upcoming week. We're gonna start using the goniometer.
Okay.
Yeah, so we're gonna start measuring different ranges of motion through different joints. That was pretty much it. The sensory testing and reflex testing in PT exam. We're gonna roll into evidence-based practice next.
Yep. Okay. Or I'm sorry, we got a clinical science.
Clinical science.
Clinical
Okay.
science next. All right, I'm taking this one. All right, so we're continuing to get ready for our exam, which just kind of seemed like it was coming out of nowhere.
Yeah.
We knew we didn't have one for a while, but now it's here.
Yep.
And so we have this on Thursday. We're still going through, so this is, he described it as like a, kind of like a foreign language class. So we're learning about medications and just general medical terms that I'm not that familiar with. So it's kind of going over my head a lot.
Yep.
But we dealt with tissue healing, getting the right terminology based off of an injury. So you hear people talk about, oh, I strained my ankle.
Mhm.
Like I just they rolled their ankle. I strained my ankle. Well, technically that's not the correct term that we would use in a medical profession. We would say that's a sprained ankle. So then we graded sprained ankles like 1, 2, or 3 grade, I believe. And then the same is with muscular tissue. We use the strained word, the
Yes.
specific strained muscle, sprained ligament. So that's where we're trying to differentiate those terms from our layman's terms that we may be familiar with, but when we're talking medical professional to medical professional, we need to get those hammered down so that we're relaying the same message across the board. We went into the different stages of inflammation, spoke more on how acute inflammation post-injury is where we need to kind of ice, make sure that we get that inflammation out, but then over time we need inflammation to occur for healing to occur. And that goes for skin, for bones, for muscles, all of those. Then we also got into tendonitis versus tendinosis, I believe.
And
So-
then the umbrella term.
Tendinopathy?
Yeah.
All right. So tendonitis is recurring. So it's like a repetitive injury to, I guess, a tissue like a ligament or a tendon. I'm sorry, tendon. And it's more in the short term. You can heal it easier if you just rest it. So say you got bicep tendonitis from throwing a baseball. You take a few days off, rest it, you should be good to go. But if you have tendonitis and continue to aggravate the injury, then it becomes tendinosis.
Yeah.
So it's just one of those things where we're trying to get the terminology squared away. I'm still struggling with it, as you can see, but it's something that is important as we are referring to other health professions. We got to get on the same page, so communication within that. Anything to add to our clinical science test as we get in? I think we got a little bit more medical medications that we're going through, talking about inflammation, and more to do with that on Tuesday for our exam.
We did talk a lot about like the clotting cascade, as far as when you have like soft tissue, going back to the soft tissue repair, if you have any kind of wound, whether that be an external or internal wound, the clotting cascade and the intrinsic and extrinsic pathways. He kind of like hammered home the whole cascade of like it going from thrombin to fibrinogen. It's a tough word to say. To
Foreign
fibrin-
language class.
To fibrin, and then the fibrin is the essential component of the blood clot. So we talked a lot about what happens as far as blood. At first it vasoconstricts, and then it vasodilates, so blood rushes to the area, and then the white blood cells come and start helping repair, and that fibrin gets there, starts that clotting process, and I'm not even going to say what I think is on my mind because it's probably incorrect. I have some notes in front of me, but it's just some basic stuff to tissue repair that we kind of have to learn. because tissue healing is important to the PT world, because we need to know those acute, subacute stages and how we can help contribute to the rehabilitation of the person. Kind of like going back to what you talked about with an ankle roll or whatnot, icing it at first, and then after that you actually need to increase blood flow to the area and start putting it through range of motion exercises and strengthening exercises to start breaking down that tissue and the whole joint, and everything starts to repair. That's pretty much all I had to add to that. It's kind of the boring, in detail pathology stuff that nobody really wants to hear.
No, it's true. I think this is probably if you were honest, and I think he's been honest as well, like this is the part that we don't necessarily want to, or that's not what we got into PT school for, but it's necessary now. We're respected in the medical community as doctors of physical therapy, and if we're going to be seeing patients direct access, we need to be able to understand what's going on at the cellular level. So just increasing our knowledge every day. It's not going to happen overnight, especially with us not being as familiar with this part of it, but the clinical science is going to be important for us in the future.
All right, let's jump into evidence-based practice.
That's good.
Okay. So this week in evidence-based practice, we have a quiz. I guess we'll find out on Monday what that quiz consists of, but I mean, really all we've talked about is some of the real basic components of evidence-based practice. And we left off last week talking about questions, using the library and questions having 4 components. So we talked a little bit more about the PICO questions. So the PICO is the 4 components. The P was the patient details. The I was intervention or exposure, so like the testing measures, predictive factors. The C, comparison testing, interventions or outcomes. And then the O is the outcome. So those are kind of the 4 main components of a question that you want to use while you're searching the library in these different databases. And then we kind of did a little bit of practice in class. So we took a PICO question that she gave us, and we broke it down, and we put it into PubMed, and we used the different ands or ors or subheadings and tried to figure out how we could narrow down the topics. Because if you're going through a bunch of abstracts and you put 1 or 2 terms in and it breaks it down to like 10,000, that's probably not good. If you put 1 more term in, maybe it comes down to like 200, and then you're like, okay, maybe you use a subheading, an and or, and all of a sudden now you're down to 30. That's more of a reasonable number to sort through 30 abstracts to figure out if it's relevant to your particular case. So that was, something that we've kind of done before, but she gave us a few more tools to help eliminate and break it down even further. And then,
especially with a database that I didn't use that much in undergrad. I used PubMed kind of recreationally, to just find something that was interesting, but not diving deeply into it to get specific and be useful in like a research project or something like that. Never did that. So this is kind of the practice for me on that.
Yeah, so it's pretty good. And then we just talked a little bit about citing sources in the AMA format. So again, we have that quiz, and then we had an assignment that's due, basically taking a question and breaking it down by those 4 components I just talked about, and then generating 5 articles that we thought were best relevant to the topic. So that was pretty good. That's pretty much it. It's a pretty quick class. We only have it once a week, so we'll say that is the wrap up there, and then we'll...
And I have the last topic of the day for professional topics. We're looking again, so this one's kind of where we just jumped off of our ethical issues that we've been facing in the profession. We learned about ethics within PT, just in general, using our core values set out by the APTA. Now we're moving on to kind of where we're trying to figure out what are we in the professional scope of things. What is a PT in the words of legislation? And so we had a worksheet that was pretty cool. I thought it was pretty cool, or it was eye-opening to say the least. What our professor did was gave us a worksheet that had probably 10 health professions on it, and there were probably 7 or 8 paragraphs describing the profession in legal terms. And so it would say, like, in the scope of blank practice, this professional is qualified to do this, 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 and this. Well, then we went through and just read the whole paragraph and tried to deduce from their skills or where they're able to practice what the profession was. So you would say, oh, this person's an OT, this person is a massage therapist, this is this and that. So we had to think through it, and we noticed that so many things overlapped. So then we had to step back and think, okay, so if this person's able to do what we do, what makes us a PT? What makes this person an OT? Where is the line drawn? And that's what it really was about, was there's a lot of blurry lines within the professions. We're all a team in healing a patient. So there's going to be skills that overlap. There's going to be other professions that do massage therapy. PTs do massage therapy. A massage therapist, that's more their forte, I guess you can say. And they just specifically do that. Well, we also do referrals as PTs now. We do this, but some other people do referrals. So it was interesting to see that we all do very similar things, and when we're talking in legal scope of things, it's hard to differentiate or to say this person's only going to do this and this person's only going to do this. So that got the ball rolling, and we just had little arguments within the class like, well, this is what this is this profession, and that's how it should be. So we just got into the argument through that and just getting ourselves acquainted with the fact that other professions do some similar things that we do, and we do similar things as other professions. So that's what this class is all about, is getting us into a different mindset as far as our job, our career. So that's really all I have for that. We got our big week coming up, like we said at the beginning. So focused on pretty much 3 classes, I guess. 3 classes. Short term, we have the evidence-based practice quiz tomorrow, and then a lot of clinical science and kinesiology review and practice to go. So
And it's going to be a busy week.
we'll have some experiences to talk about next week for sure. So
Should be a good breakdown next week.
yeah.
Hopefully good things, all good things.
Hopefully all good things. So we're going to do well.
Yeah. Just another note, Grand Valley's football team did win this past weekend.
3-1 now.
So
3-1. Mizzou didn't play, so they didn't lose. That's all I got to say. They didn't lose. I don't know even who they're playing this week. It's not good this year.
they haven't been good since what, Chase Daniel?
No, they went to the SEC championship.
Oh, they had that one
years.
quarterback. It was
Yeah,
pretty good.
they had a couple decent years ago.
Yeah, that was a while ago. But all right, yeah, that's all we have for you today. So thanks for watching. Anchor up, go blue, and that's all we got.
That's it. There we go.
All right, thanks a lot, guys.